I'm the Vice Chair for the Child Psychiatry Division, and I'm very excited to introduce our speakers for today for the discussion of the Behavioral Intensive Care Unit, also known as the BICU, at Children's Psychiatric Center. And we have three accomplished presenters today. The first is Dr. Anju Jaiswal, who is a child and adolescent psychiatrist who works as an associate professor here at UNM. She is our inpatient medical director at Children's Psychiatric Center with more than 15 years of clinical experience in the inpatient child psychiatry, with a passion to provide developmentally appropriate care at different levels. And secondly, we have Dr. Artemio Brambila, who is a professor at the Department of Psychiatry at UNM and is a clinical psychologist with extensive experience and expertise in inpatient milieu interventions. He is the clinical director at Children's Psychiatric Center and has been leading specialized programming for BICU patients. And third, we have Dr. Tomoko Hamma, who is an assistant professor for child and adolescent psychiatry with a background in basic science research, who has been instrumental in implementing specialized programming with multidisciplinary team while working as the inpatient attending with the vast majority of recent BICU patients. So I will turn things over to them. Oh, are you starting, Dr. Jaiswal? I think you're on mute.
Oh, sorry. Hi, I'm Anju Jaiswal. So I will be starting the presentation. Can you all hear me?
Yes.
Okay. All right. So first of all, we want to acknowledge the original people of this land where our Children's Psychiatric Center is located, the Sandia Pueblo and other Pueblo committees in Navajo Nation, who has given us this opportunity to connect with the broader community of New Mexico and do our work that we do here. So today's topic is about Behavior Intensive Care Unit at Children's Psychiatric Center. As the name implies, it's an ICU for the psychiatric patients. In regular literature and common terminology, it is interchangeably used with psychiatric intensive care unit, which is an inpatient ward with higher staffing ratio to accommodate patients with higher risk of danger to self and others. In BICU, there is an emphasis placed on the application of behavior and environmental approach to the treatment of complex acute psychiatric conditions. The description of one PICU or BICU cannot be generalized because it differs in different hospitals and countries for the number of beds or patient demographics. First time, the description of PICU is found in conversation literature to be appeared in 1970s in UK and US, and in around 1980s in Australia and Canada. PICU are very similar in UK and Australia, where they are small wards with higher level of nursing and other staff built as an open plan designed to ease observation. So usually there is a central designated area where the nursing and other staffs are located. And then there is an elliptical fashion of design where different rooms are located, where there is an option of people to be able to be visible. And usually those are 4 to 6 bed wards. It is often locked ward, and sometimes there is a seclusion room inside that ward. It is less well defined in US and Canada and seems to vary a great deal compared to UK and Australia. In United Kingdom, there is an association called National Association of Psychiatric Intensive Care Units, which provides guidelines, regulations, and also has their journals, which publishes things how this system works and what are the best practice methods in that. However, in the United States, there is no such organization or association to guide and regulate. So most of the literature that is found about this type of intensive care unit is based on studies done in UK on adult population. So a little bit about the historical perspective of BICU at CPC. Initially based on the patient care needs in our local community in New Mexico, it was created in 2003-04. There is no other BICU in New Mexico for sure. However, there are very few in other child psych hospitals all over the United States. Initially, it was designed for acutely psychotic patients who are often unpredictable in acute milieu for quick medical stabilization for a short duration of time. Patients were directly admitted from community with identified BICU spatial programming based on the admission criteria. Over the course of year, since 2003-04, BICU interventions got gradually modified due to a variety of patients who presented with significant dysregulation and aggression, which was very difficult to manage safely in acute regular units. Due to increased need for acute management of developmentally delayed children and autistic spectrum disorder patients, during last few years of our clinical practice, we have been needing to revise the guidelines in 2021 for admission in BICU. So a little bit about how is the structure of BICU is at CPC. So as some of you know who have been exposed to rotations in Children's Psychiatric Center, it's a specialized unit designed for the most acute and functionally impaired youth, where close monitoring is provided with implementation of focused individual and special programming for medical stabilization. And this is how the outside entrance looks. And I would like to show a short video about how it looks. So let me just change. So as you can see in this video, this is the entrance for the seclusion rooms. We have two different seclusion rooms which are visible here. Each room has padded walls, and this is the mechanical restraint room. And this is actually the entrance of the BICU. So once you enter there, there are some couches for the child and staff to be there. This is the bedroom where there is a mattress and the walls are padded. So if the child is engaging in any kind of aggression or banging their hands or head, then they sustain relatively less injury. There is a television there for them to be able to watch some educational stuff or cartoons, depending on age and ability of the child. There is an adjacent private bathroom, including a shower where curtains could be placed. And it opens to a backyard patio area, which is connected with the BICU, where kids can go and do different programming, including some sensory stuffs. So they're not always completely locked inside. There is 2-to-1 staffing at all the time, and it is connected with an acute unit called Chaparral, which has 8 inpatient beds. Okay, so this is the actual floor plan to show exactly how the structure is. So this is the outside area, like field ground. This is the entrance where on the left side, this is the acute chaparral unit with 8 beds capacity, where regular programming happens. And there is a nursing station here, and this is the entrance that I showed for 2 different seclusion and restraint rooms, mechanical bedroom, and this is the entrance to the BICU area, BICU bedroom, restroom, which opens to BICU patio. So in these seclusion rooms, there are other kids who sometimes are brought in when they need to be in this seclusion situation from either this acute unit or sometimes from other acute units in the hospital where they do not have their own individual seclusion room connected to the milieu. So a little bit about our CPC campus. We are very proud and fortunate to have open area for kids to engage in different activities outside of just the bedroom and milieu structure. This is the open field for the volleyball court, some other for little kids, some other activities. This is the dolphin fountain area where we sometimes do dolphin ceremony. And these are some open areas where kids can sit and engage even in individual therapy. This is another nice small area where we invite music therapy and do drum therapy here. This is the art room, which is a newly decorated art room with all current JCO requirement related furniture to clean properly. The good part about this room is that it's adjacent to the patio area that I showed earlier. So a kid who is participating in BICU activity can come here and do certain art activity at different times. However, it is also utilized for other kids in acute milieu who can come as a group and do different activities. So these are some of the things that they make. This is the paper lanterns, different painting activities. Sometimes we have clay modeling activities, and this is actually the school building where they have a hallway where they can play Foursquare if they're not able to play outdoor for weather or other conditions. Again, we have a huge field in the middle where they can play football, soccer, or just take long walks with the staff and therapist. This is a volleyball court. This area is their cafeteria to eat lunch. And sometimes BICU patients, if they're stable enough, can go there with the 2-to-1 staffing ratio when other kids are not there. So a little bit about the BICU admission criteria. So kids who are finally admitted to that unit obviously have significant issues. So some of the target symptoms are extreme mood swings, aggressive behavior, danger to self or others, behavior significantly affecting others' treatment, and hence it's not practical or beneficial for other kids to be treated around them in acute milieu. Severity is significant with imminent danger to self or others. The regular programming are not being effective enough, and we maintain all the regular guidelines to make sure that it's the least drastic measure to treat them to avoid any kind of long-term restraints or restrictions. At CPH, all programmings are based on multidisciplinary and multimodal approach. So it's not just 1 or 2 people who are taking care of the child in terms of medication management, etc. It's a variety of people who are involved, and specifically in BICU, Each individual has a specialized program with the incorporation of a psychiatrist, a psychologist, or therapist, behavior specialist, also called educational specialist, psychiatric nurse, mental health tech with 2-to-1 ratio. At any time, there are 2 staffs with 1 patient in BICU. Pharmacist, special education teacher, utilization review, working with insurance company, and community support worker to start working on discharge planning. We intermittently have requested OT, PT, speech dietitian referrals as indicated. We are lucky to have our pediatrician here who provides and closely work with us. We have consultation with the medical director, clinical director, and executive director, and we do have a big role because BICU does not just require simple intervention, but also require a teamwork, including many changes that happens all over the hospital to accommodate the right kind of programming for this particular patient. So as I mentioned, special program is created. The environmental is a low stimulation environment. So there is a lot of sensory support provided for these individuals, which may include like water play, weighted blanket, play-doh, kinetic sands, drawing, coloring. We have a huge blackboard inside that BICU area where they can draw pictures with chalk or write and work on their DBT skills, which is our milieu therapy programming, depending on the ability of that particular patient. It is very closely monitored, and we have Q5 checks and observations, which are documented on a paper sheet. We are able to do rapid medication adjustment with consultation with pharmacists. We do have option to do neuropsychiatric evaluation, psychological testing, or functional analysis of the patient as indicated depending on their diagnosis, which is a unique service which was added later in last couple of years for this particular population. It's a great learning environment for residents and fellows, which is, as I mentioned earlier, is not available in many places in USA. A little bit about the literature review. So there is very limited data on BICU or PICU patients in acute inpatient child psychiatry literature. There is practically none, but we found some articles which discusses these units from nursing perspective, mostly in adult ward. One of the literature in 2008 had some of the good information where they identified the typical PICU patients are male, younger age, single, unemployed, suffering from schizophrenia or mania, or from a Black, Caribbean, or African background, usually legally detained with a forensic history. Most common reason for admission to PICU was aggression management, and most patients stayed there for a week or less. The evidence of efficacy was not so good based on that particular research. There's another retrospective study done in 1989 by Musisi using official records where it was shown that after 6 months of opening PICU, a lot of measurements went down in terms of staff accidents, patient accidents, time lost to inquire, time lost to injuries at work, nurse absenteeism, constant observation needed, seclusion hours, number of patient seclusions. It's not very clear whether all these improvements were just because of PICU opening or it was a natural variation due to treatment over course of time. So definitely there is more need for systemic evaluation of these kind of interventions. So just a couple of lines about admission to BICU. It's a process which requires involvement of different people to make the decision about which patient is appropriate and how they get admitted. So there are different modalities of admission. One is from direct admission from psych emergency services, PES, Ph.D, or from university hospital, where referring provider reviews and discusses it with the CPC medical director, executive director, and the acute unit director to decide whether this is the appropriate patient and whether we can really manage the needs that are required, because there are steps that needs to be taken in order to open a BICU, to provide appropriate staffing and other needs to manage the patient safely. Another method of admission is if a child is admitted into acute unit, however, is not really able to be safely maintained or is not meeting enough treatment options that we can provide, then we decide with the consultation of that particular unit's attending and approval of all the other parties, as mentioned before, to make sure that we can open it. And then the case is discussed and all the are discussed with that particular unit's nurse who coordinates with the CPH hospital-wide regarding the logistics of transferring the patient, and then the patient or guardian is notified, because we all know that BICU is intensive care unit and it has way more restrictions at the beginning for the patient. However, it also provides a lot of support that cannot be provided in regular acute unit. Now I hand it over to Dr. Brambila to talk more about some of the admission criteria.
Good afternoon. So one of the things that Dr. Anju was kind of saying was the notion that way back when in 2003, maybe we had maybe one, maybe two, maybe even three BICU patients during that time there. But around 3 or 4 years ago, all of a sudden we started seeing more patients in the BICU. And it got to the point with the last year, for example, we had like 90% occupancy of the BICU. And at the same time, when we had this occupancy, it was the kind of thing where we had other kids in the units who could benefit from the BICU as well. And so in some ways, it got to the point where how do we actually have these multiple patients that could all benefit from the BICU? How will it be more of a standardized way of making some decisions? And so one of the things that we did was looking at, can we develop an algorithm in which we can be able to have more kind of standardized decision-making processes across all the units as well. And so one of the things that we developed was looking at how to be able to define the problem in 3 steps here. The first one was taking a look at the patient is specifically, are we looking at the BICU? Is there more the SI or HIs, brain passive neglect, the quality of life? Quality of life would be an example of perhaps a person that is homeless with significant psychiatric problem as well. Also want to take a look at the variable of determined severity. Are they imminent threats? Do they have a really complex medical condition? How pervasive is their presenting problem, and the complexity as well. At the same time, we also want to kind of find out what are some of the immediate psychosocial stressors that the person may be experiencing. Would there be a kind of something drastic happen in the family system, or something happen in the unit? So in some ways, kind of understand a little bit more in the context of what these presenting problems we're kind of presenting. Can we have the next slide, Doctor? So at the same time as we're kind of defining these 3 steps here, we also want to take a look at the notion of what's going to be the immediate intervention. What are we targeting here? Are we looking at medical stabilization to maintain the safety, reduce the target behaviors, maintain autonomy in the unit, maintain milieu, and safety discharge planning? So from the BICU perspective, we're actually looking at, gosh, the focus can be the medical stabilization, maintain safety, and reduce target behaviors, and looking at reducing target behaviors in the context of the discharge plan. Are they going home? Are they going to another out-of-home placement? So in some ways, also take a look at targeting those things as well. The next one. So what I have here is kind of a determined level of immediate intervention required. One of the things that because of the BICU is such a restrictive environment, we want to be able to care for the patient in their least restrictive environment as well. So I'm going from left to right, from level 1 to level 3. We take a look at a patient, for example, coming in level 1. In essence, this is your typical CPC patient who comes into the unit, where they come in with either internalized or withdrawal or internalized or externalized behaviors, may exhibit some behavioral problems. But at the same time, the severity, once they're there, there's not so much presented as dangerous, or they can be potentially disruptive. But by and large, they can benefit from medical stabilization, and they can maintain themselves in the milieu. They can go to school, and they can benefit from all the ranges of programmatic activities that we have as well. But by the same token, if somehow, some way, if we have a particular patient who may be level 2, they're consistently more agitated, they may engage in property damage, or they can engage or not engage in our groups. Can they engage with the attendings or in therapy as well? So these are the kind of kids that we want to be able to take a look at how do we actually begin programming differently. At the same time, we're also going to assess their severity. So they're still kind of acute, but they're not in imminent danger. So one of our primary goals is then how do I can continue with the medical stabilization? How do we reduce the target behaviors, the aggression, and disruptive behaviors? In the next slide, I'll talk more about the interventions we use as well. As we progress to level 3, so if the individuals who is in the level 2, all of a sudden they continue to escalate to the point that they're aggressive towards staff or towards peers, where they're looking at presenting danger to self or others. And the thing that we'll also notice is to what extent is their behavior affecting their other people's treatments as well. When we start seeing that, we're looking at the notion of, gosh, not only the imminent danger, but perhaps we need to look at a placement as well. If we go to the next level, next slide, please. So these are kind of the different kind of interventions that we have that correspond to each level here. And again, level 1, we can benefit from regular milieu programming, the ABPH programming, and so forth. In level 2, this is where we're trying to try every which way to maintain the patient in the unit. We look at our high-risk precautions. They need to be contact restriction, or HRP, or high-risk precautions, or line of sight as well. And so these are kind of interventions we want to be able to do. At the same time, we also look at the interventions. Do they need to be on PI for the peers, like peer isolation and separation from their peers? Do they need to have a staff that's one-on-one? And the way we kind of operate at CDC, whenever a patient is on one-on-one, it automatically triggers a special program where we focus specifically on target behaviors and come up with a series of interventions in order to kind of stabilize them as well. And that one-on-one may also kind of entail, is this child, can they benefit more from a different kind of track system here? Here at CPC, we have 3 track systems. Track A is a track that we look at kids who are ASD, who may have intellectual disabilities or other neurodevelopmental challenges. And so they have different kind of needs, both behavioral and programmatic needs as well. So we try to accommodate within the context of one-on-one, a specialized program for them to be able to target those behaviors as well. And then target C is, or track C are the kids who we find who are maybe acutely psychotic, who benefit from close monitoring and supervision. And also track Cs are our kids who also may have had a kind of acute psychosocial stressor. They may experience some trauma or some stressors where they may be kind of fragile. And so they may, again, benefit from individualized attention. And another thing we consider at level 2 is, gosh, can this person benefit from being in another unit as a way to kind of change the dynamics of interactions that the person may have with other peers and staff as well. While they're in the BICU, as Dr. Jaiswal kind of mentioned, one of the things we do is we do ongoing evaluation. We determine whether or not they can benefit from more specific and focused psych testing to school testing, but also we're looking at using the framework of the ABA, doing more of a kind of a functional analysis to determine some of the behavioral needs of the kids as well. And when we get that information, we're better informed by which to be able to develop special programs for them that kind of targets the behavior that they're manifesting as well. At the same time, we're also looking in terms of the discharge plan. What we notice is much of our kids, because of their presentations are very complex, we want to be able to be more proactive in already identifying what's going to be the discharge plan in order for us to kind of mobilize and know exactly how we're going to cater our programs for that as well. If we know the next program, the next slide. So one of the things that we, whenever a kid's in the BICU, we have an ongoing monitoring and evaluation, not only of the medication, but also program as well. We have daily rounds in which we just we review all the Q5s, the feedback from the staff. We review the notes, and we take a look at what needs to change or not change. And so we have we try to implement in a very proactive manner and implement any kind of new information as we go here. At the same time, we'll also kind of solicit all information for all folks who may have had contact with our BICU kid, whether it be the unit staff, as well as the nurses and so forth. So we want to have a multidisciplinary approach to gathering information and so forth. At the same time, because of the complexity of some of our cases here, we try to endeavor to have at least weekly rounds in which we actually discuss with the medical director as directors as a way to kind of take a look at what are administratively, clinically, medically, clinically, what are some of the things that we need to kind of all come together and be able to kind of implement as well. The next slide, please. And this is a kind of diagram that kind of describes the idea of our discharge options. If we're looking at this our BICU kid going straight home, then we're going to certainly take charge in looking at developing a discharge plan to home. But we also know there's kids going home that we also want to be able to really kind of target some of the behavior and work through some behaviors, knowing that the parents and outpatient providers are working with them as well. So we may actually try to address more multiple problems in order to kind of make that transition home much easier. In contrast to if somebody's going out of home placement to another RTC within our state or out of state here, then perhaps we're not going to be as comprehensive in terms of trying to target multiple behaviors, but rather we just need to kind of medically stabilize, being able to kind of target the aggressive behaviors or ADLs, for example, and then they'll be ready for the discharge process. And the last one is looking at again, discharging home, and also part of the assessment is in discharge planning is what is it that we're looking at in terms of what can we do in terms of wraparound services as a way to maintain this person in their community. What do we need to do with the schools in kind of wraparound services? And what are some other services that the parents can benefit? So these kind of things we're trying to imagine what are some of the wraparound services in order to minimize the risk of the relapse as well. Next slide. And so these transitional strategies has more to do with the idea that if we're looking at the kid being discharged to the home, there's some behavioral strategies, techniques that we use based on behavioral modification, whether it be shaping, whether it be strategies as well. And Dr. Jaiswal kind of mentioned the idea that sometimes if a kid has difficulties with loud noises and has difficulty with peer interactions, we may use the cafeteria as a way for them to kind of go to the cafeteria by themselves and with their 2-1 staff. They're used to going to the cafeteria. Then slowly but surely, as they become more exposed and more comfortable being in that particular room, then we may have them go to the lunch with other kids as well. So some way, again, using the part of the shaping and exposure strategies in that way. So that can be more like an example, how do we actually begin the transition process either back to another unit or home as well. The next slide. I'm going to pass it on to Dr. Hamma here.
Okay, can you hear me?
Yes.
Okay, all right, okay. So as Dr. Jaiswal mentioned that there is some trend in the typical BICU, PICU patient, but these are found in adult. And there are almost no literatures I could find describing about BICU, PICU use in acute child and adolescent inpatient unit. So I got very curious to find out about the patient profile in BICU at CPC. And in order to investigate this further, I was able to obtain the list of patients who were admitted to BICU for a little over the last 3 years. And there are a total of 26 cases identified during this period. And I just wanted to mention that this is a descriptive study without any statistical analysis or control. But what I'm going to show you today is, I think it's interesting for me, at least, and other people, hopefully, and also important for improvement of patient care and the best practice of the patient in BICU, as well as discussing specific need at the CPC and in the community. And this graph on the right shows the person occupancy of the BICU per year. As you can see, there are some fluctuation between years that BICU has been used very frequently, especially last year. There are almost 70% of time used. Next slide. Next slide, please. Okay, now you can look at some demographics. Among these 26 cases, patients are likely male, 14 years or older, and their ethnicity is white Anglo. In the state of New Mexico, anybody 14 years old and above can consent for treatment and medications. And this means that if the kids does not want to be in the hospital, we need to commit them through the mental health court. And also, if they do not have a capacity for certain treatment or procedure or medication, then we need to assign a treatment guardian. Most of the time, it's their parent or legal guardian. Next, please. And most patients who are admitted to BICU are actually voluntary admitted. Oh, not that one. Go back. Okay, thank you. So most patients admitted to BICU are voluntary admitted. And for the case of 13 years and younger, the parents are okay for their kids to be admitted to the BICU and receive treatment. And there are a few patients involuntarily committed to the hospital and with or without treatment guardian. And among these 26 cases, again, most of them are voluntarily admitted. Next slide. As Dr. Jaiswal and Dr. Brambila mentioned that there are two different ways for the patient to be admitted to BICU. There is no longer a way to admit patient directly from the community, and all the patients need to be evaluated through the emergency room before they come to BICU. And let's see. So among these 26 cases, there are 19 of them. They are admitted to the BICU after they stay for a while in the acute inpatient unit. And the days before BICU admission varies from 1 to 41 days. So it's pretty variable. And there are a total of 7 cases. These kids are directly admitted from the emergency room or main hospital to BICU. And all these cases, except the CL from CL service, we have very close communication with them. So direct admission can happen very smoothly. And from PED, PES, the patient are evaluated upon the arrival to the CPH to be determined for the BICU admission or not. Yeah, next slide, please. To find out the reason of the BICU admission or transfer, basically to see what criteria these kids are meeting for transfer. The documentation by psychiatrist, therapists, or mental health stakeholders were reviewed while looking for specific keywords such as dysregulation, tantrum, self-harm, threat, agitation, or disrupting, and also looking for specific event that, for example, inappropriate sexual behavior, distraction property, things like that on the day or prior to the BICU admission. And so one patient can have multiple component of these criteria as a reason of transfer. And among BICU admission criteria, we see extreme mood, disruptive symptoms, and extreme behaviors as top 3, followed by the aggression, which is a little bit different from the literature indicating that for adult, reason of BICU, PICU admission is mainly for aggressive management. And I think that the high rate of the disrupt symptom being in the reason for BICU transfer at CPC may be contributed by the program we run at CPC. We have very structured program. Kids have a schedule, go to cafeteria to eat, go to school, DBT group every day, learning skills every single day. And so each patient follow this track, but the program run as a unit. So if there's one acutely ill patient who is disrupting, this can affect the entire unit or entire patient. So that may be the reason the disruptive symptom is one of the reason for BICU transfer. Next slide, please. And this is looking at the primary diagnosis appear in discharge summary of the patient admitted to BICU and categorized into DSM-5 classification. For example, for schizophrenia-related disorder, including schizophrenia, schizoaffective disorder, unspecified psychosis, catatonia with psychosis, and so on. And what you see is that depressive disorder, bipolar-related disorder, and schizophrenia-related disorder have equal distribution of occurrence, followed by neurodevelopmental disorder. It'll be very interesting to compare this with the diagnostic profile of all the patients who are admitted to CPC. Next slide. Many of the patient carries multiple diagnoses. For example, one patient have a MDD, recurrent severe without psychosis, and bulimia nervosa, and body dysmorphic disorder, and cluster B personality trait, and general anxiety disorder. So here, just looking at the comorbid diagnosis separated from the primary diagnosis to see their frequency. And as you can see, for me, the slide is pretty difficult to see. The quality is pretty poor, but what you can see actually here is that the top 5 of them are ADHD, intellectual disability, anxiety, substance use disorder, ASD, and also depression. These are notable. Next slide. Wow, I cannot see how much. I don't know if you guys can see. Among 26 cases reviewed, the autism spectrum disorder and intellectual disability actually or these 2 diagnoses occurred in 50% of the patient, and their symptoms can be ranged significantly from nonverbal needing significant ADL assistance to higher function. And in fact, there are only 4 cases where the patient had primary diagnosis of autism spectrum disorder related to BICU admission. But it is striking to me that this high rate of having these diagnoses in patient admitted to BICU. And on the left side, this pink panel is actually my note to keep track of the patient and some of the things I found from the chart. And it's the number of the patient in the order of old to new. So the top is 2018, bottom is 2021. And as you can see, you see a lot of ASD-ID happening, diagnosis in these patient recent years, and where the psychosis was more in the old time. So, okay, next slide. Okay, so lengths of BICU stay varied significantly from 1 to 158 days among these 26 cases. And 158 days stay in BICU is one of the longest we have had at CPC, as long as I know. And that occurred last year, and it was an outlier. BICU stay can be short or long. And why the stay can be so long, there are multiple reasons. Like Dr. B mentioned, it takes long time to stabilize the kids, and also difficult to establish a safe discharge plan. And also patient is not able to, one other thing is the patient is not able to return to the unit due to milieu environment is not stable enough for them to go back. And that case, the stay can prolong. Next slide. And this is the length of BICU stay per primary diagnosis and few other diagnoses that are likely associated with prolonged hospitalization. Bottom line is that there is nothing really stand out, except that there is a possible sign of patient with ADHD, ID contributing to maybe longer BICU stay. Next slide. Okay. And seclusion and restraint event can occur even in the BICU and to the significant amount. There are some cases that close to 10 restraint occurred in one day. And although not all of the restraint are like the one shown here in the picture, some of them are less than a minute or a few minutes. And for example, in a situation where the staff is assisting patient ADL and patient impulsively swing their arm, staff has to hold their hand, and this is a restraint, so we have to report. And high number of restraint in BICU creates a lot of stress to staff and patient, both physically and mentally. And actually one morning I went into the nursing station, and the unit nurse was struggling to fill out this, literally the pile of papers to report for these events. So I feel eliminating redundant process and making things simple and paperless is very important, not only just to take care of BICU patient, but other patient as well. And among 13 cases where seclusion restraint occurred in the unit before patient was transferred to BICU, seclusion and restraint event were both increased and decreased. And after BICU transfer. So one concern I have is that the 50% of these increase actually increase more than double. And again, high number of these events were seen in autism spectrum disorder patient, ASD patient. And this makes me wonder that BICU may not be the best therapeutic environment for the patient in this population. Next slide, please. In about half of the cases, 14 out of 26, 54%, patient returned to the unit after stabilization at BICU and then discharged. And the rest of them, they were discharged from BICU directly. Among all of the patients who went through BICU, many of them are placed outside of the home for further or in-depth treatment at a residential treatment center. Because there are very few residential treatment facilities in New Mexico, many kids went to out-of-state facility, which is not ideal. Discharge planning of very complex patient to home is also very difficult with limited resources available in the community. The partial hospitalization program, more of these intense outpatient program, or the home-based program that may be the best, such as multisystemic therapy, family functional therapy, community and family therapy are definitely needed to not just support the family and to prevent the readmission, but also to assist the patient during the recovery. And among these 26, one was discharged to the Youth Detention Center, YDC, after the patient assaulted the staff in BICU. And the last one was discharged to main hospital because of a medical emergency. But after the long recovery in the main hospital, this patient was discharged to group home. Next slide. So I have cases, but there's no time. So I will send back to Dr. Jaiswal. Okay, thank you.
Yeah, so for the sake of time, I at least want to show a couple of other stuffs that are important. As we all know that the BICU treatment is not just dependent on the providers from our side. There's a significant role that we have identified our staff playing. So we want to show a little bit of perspective from their side. So let me just try to share that video.
Hello, I'm Andrea. I've worked here at UNM Children's Psych for about 22 years. I've worked with several different patients in the BICU. How I would describe the BICU is a small area where it's self-contained, where we can treat a lot of children individually, one at a time, treat children who benefit from more specialized and one-on-one attention. I would let new staff know not to be afraid and to communicate with the staff that they're with. They would always be with a more seasoned staff. I would let the new staff know to always check the treatment plan, and if they have any questions, to always ask questions and to bring up any ideas, things that they think of that may help us find new ideas for new incentives or programs. We are working with a more challenging population. We do experience burnouts. Working in the BICU with these challenging patients sometimes can lead to mental exhaustion, as well as a few more assaults.
Hi, my name is Felicia Nevadas and I work with the Center for Development and Disability. I am an educational consultant with our autism programs. I am at times helping support staff within the BICU, which is the Behavior Intensive Care Unit. And while I'm there, I am helping guide staff and kind of in that investigation process of figuring out what is going on and what we can do to help support the patient that's in there. There are different criteria that help or get a patient into the BICU setting, and some of it is behavior or self-injurious behavior to self or to others if they are unable to be in the cottage around their other peers. Within the BICU setting, this allows us and staff to provide some different interventions that we normally would not be able to provide just because of the environment that we're in, meaning the different items that are in the room or the patio that is right outside the BICU that we are able to access when our patient is safe enough to go outside. We have different things that we've been able to bring in, like maybe a little swimming pool that they're able to stick their feet into and allow that as a different output when they are in the BICU, rather than not having that when we're in a typical cottage setting. Some of the challenges I've had is just it's different each time. Each patient makes it completely different, and so as much as we try to develop it and make it mainstream, at times we have to take a step back and figure out what we need to change and what we need to do to fit individual patient needs.
And Dr. B, if you want to quickly say in a couple of lines about this survey of the staff, please.
One of the things I want to do, we did a quick BICU survey, and we just want to kind of get a sense of the perspectives of the staff. And one of the things that the take-home message was basically, when the BICU worked, it was because we were communicating and coordinating between all the team members. Conversely, when it didn't work, because we weren't communicating or coordinating either. And that kind of speaks to the complexity of the kid, as well as the different kind of shifts that we have. They have a day and evening and night shifts as well. And so that's one of our, we feel good about in terms of communication, but also areas that need improvement as well. So that kind of wraps up my piece there. If you want to go to the next piece there. So I'm done with my piece, given the time that we have here. So I wanted to.
Okay, so I won't go into too much detail about this part because we have kind of touched on what are the benefits and advantages of BICU. Definitely, we have bent over that part. There are some challenges and pitfall of BICU. Definitely cost-wise, it's not as effective because we often have to close some of our beds in order to accommodate one patient in BICU, which can sometimes interfere with other acute patients' needs. There is a high demand of burnout potential, so there is need to emphasize on wellness, staff safety. There are more number of seclusion restraints and assault towards staff with some of the aggressive patients. Sometimes we have more than one patient who requires BICU, and we had to modify our programming to accommodate that, which makes some of the things very complex. There is more need for staffing education and other information for everybody. So I'll just leave it at points to ponder. There are multiple things that we have to think about for future, whether there is more need for a different kind of more BICU beds, whether we need to separate out the ASD patient in future when we have new hospital option. Can we structure it in a way where it's a unit with more such beds with the option to separate these kind of patients between ASD patients and other aggressive patients? What are the things we can do to improve the quality control with more data analysis and research, and how we maintain wellness of the staff and avoid burnout and improve the safety of the BICU. I do want to, there are some references here for what we talked about, and I do want to thank not only just the patient staff who works in BICU, but everybody else who are working with the children of New Mexico in one way or the other. We have so many different clinics and providers who are directly or indirectly involved in taking care of these kind of patients who sometimes end up in BICU. And that leaves only a few minutes for the question, but we will be happy to answer anything at this point or later.
Okay, well, no, great. Thank you all so much for this presentation. Yeah, I see it's 2 minutes till 2, but if people had questions, I'll keep an eye on the chat, or please just speak up. Oh, well, I did just, if anyone, any theories, what changed about 3 or 4 years ago with the shift to many more patients with autism and intellectual disabilities? I don't know if any of you had any thoughts or theories about that.
I don't have any particular theory, but some of the observations that we have noticed, there are definitely very limited resources in the state of New Mexico to provide the kind of care that very aggressive autistic spectrum disorder patient needs. There are a lot of outpatient programs and program development in school setting to provide support for these kind of patients who have mild symptoms. But when it comes to real aggression, even any of the other RTCs or other kind of services, including any pediatric services, seems like not being able to handle that. So it becomes one of the last resort for those patients to get the right care is our unit. So that is a very good question that we need to really explore other options about that. And anybody else has any idea, please feel free to share.
One of the things that Dr. Hamma was kind of saying, based on our observation, is the ASD are presenting with a whole lot more comorbid presentations, whether it be the mood disorder, but also psychosis as well. So we have the unique ASD presentation that presents a challenge for outpatient providers as well.
Hi, it's Dr. Meyer from PCL. Great presentation, you guys. I appreciate it. One of the things that I wonder about with the notable increase in ASD presentations and admissions, especially over this past year, is how much COVID had to play a role in that, because I had a lot more calls through the PALS line from pediatricians and parents who were really struggling with their autistic kids now that they've been removed from, now that they had to be removed from their sort of daily routines, and they couldn't go to school, and parents were having to deal with them at home, and behaviors were escalating. And so I wonder if that has played a role, and I'll be curious to see if whenever this pandemic lessens and stabilizes, if some of those, if the numbers dip once again.
Yeah, that's a very good point.
Thank you, Dr. Meyer. So I do see just, it is 2:01, the time goes so quickly with such a great topic. So thank you so much to our speakers and for everyone for joining us today.
Thank you.
Thank you for allowing us to share some of our work.
Thank you.